Good evening, everyone. Welcome and thank you for joining us in this webinar titled COVID-19 in the Classroom webinar series. We are focusing on air and surfaces today. This is a re-recording of a prior webinar that occurred on August 31st, 2020. The information that's presented here has been previously discussed and we will review it again today in detail. Next slide, please. So we typically will take questions using Q&A. In the context today, the questions will be asked and we will answer during the live webinar, but also provide answers in a documented form afterwards in an FAQ document or address it in future webinars. And the recording will be available afterwards. Next slide, please.
Is the virus SARS-CoV-2 transmitted through the air?
So I think I'm going to go to Dr. Weber to start this off, and then I will pick up on the next question.
Thank you very much. So the answer is yes. The major mode of SARS-CoV-2 transmission is through respiratory droplets. When people talk or if they're sick, cough or sneeze, respiratory droplets are expelled with live virus. A person, usually within, the closer they are, usually within 6 feet, inhales those droplets and acquires disease. We do know that the virus can survive in air. You can see that the rotating drum. Just think of it as a blender on its side that's continually rotating, and you can put live virus in very large amounts into it and show that it survives for 3 hours. Now, keep in mind that this is very artificial, this environment. It's rotating, so the particles can't settle because it's enclosed. The UV light, which is outdoors, helps inactivate the virus. And of course, there's dispersion, meaning as the virus spreads into larger air volumes, the amount of virus is decreased and doesn't reach a dose allowing people to become sick, called an inoculum dose. So the fact that the virus survives for 3 hours in this very artificial circumstance doesn't mean if there was a person with COVID in a room and you went into that room 3 hours later, there'd be virus in the room that's still live and enough that could cause infection, nor does it mean that if there are people walking by in the corridor in an adjacent room, or if the air is recirculated to another floor, you could become ill.
Thank you, Dr. Weber. Next slide, please.
So what this slide shows is an example of transmission of SARS-CoV-2 at a restaurant. You can see in purple in that upper middle table is the person who's sick. Several people also develop SARS at that table, but it's unknown if they got it from that first sick person or they were all exposed to the same person because they were members of the family. But you can see at the table at the left and at the table at the right where the air is flowing over, other people did become ill, particularly downwind to the left. Those tables are only 3 feet apart roughly, so the transmission is still quite close. This has been shown, you can look at that and say, well, transmission is only short distances, which it is for a person who's infected, or you could say there may be occasional circumstances, depending upon the airflow, where it could go a little longer than 6 feet. But most importantly, no one at the other 15 tables, 68 patrons, and none of the waiters became ill, demonstrating that really SARS-CoV-2 is really transmitted efficiently over very short distances, indoors, and even less efficiently transmitted out of doors. So the key points from the real world setting: all infected persons sitting with a short distance of each other have some risk if they're not wearing masks. And I want to emphasize that again, masks, regardless of how close you are to a person with COVID, if both the infected and uninfected people are wearing masks, eliminates the risk of acquiring COVID. So despite poor ventilation in this restaurant, there were no infections in those seated further away, and there were no infections in the wait staff for individuals. Again, demonstrating short distance transmission of SARS-CoV-2, but no long distance transmission. Again, it is through the air, but there is not good evidence that it goes long distances.
Recently, the CDC provided recommendations for considering HEPA filters, especially for the nurses' stations, and opening doors and windows in school. Can you tell us more about the evidence supporting this recommendation?
So the answer is HEPA filters, just so people know, are high efficiency particle filters, and they remove 99.9% of particles in the air. We use them in the hospital, and certainly people can buy them for home use who have allergies to cats, dogs, dander, or something that they want to cleanse their houses with. But in general, they're not necessary for preventing transmission of COVID. There is a recommendation in a nurse's station in schools where people would be setting who might have COVID because they've developed signs or symptoms, either faculty, staff, or patients, waiting for them to be transported to a medical location where they could be tested for COVID, that would provide an extra level of protection for the nurse. But that's very specific to use in the nurse's station there.
So I think just some additional comments addressing the issue of windows and doors. While we certainly think the more air circulation you can get into an indoor space, the better it will be, just to reduce any burden or any viral particles in the air. There are other things you have to consider when you do open doors and windows, and particularly for younger children, you have to think about noise and allergens as they're learning. So one study that tried to assess the impact of SARS-CoV-2, the virus that causes COVID-19 in the air, and how this would impact transmission, looked at samples from patient rooms. They assessed the amount of viral particles within the rooms, and also some of the other areas in the hospital, which include the hallways. They did find that they could grow some viral particles from air samples. It was detected in the air in the patient's room and in the hallway. However, this does not mean that the virus is spreading across all of these settings. And in particular, we all work in the hospitals daily. If that's the case, we would see higher rates of infection. It means they found viral particles, but it doesn't mean live viruses were present or that they can spread. And then the other thing which we don't emphasize as much is that usually when you're exposed to viruses, there's an infectious dose. So not just a tiny particle, there usually has to be a large enough infectious dose to actually cause infections. And we don't think that's what is occurring in this case when you find particles of virus around a patient's room. Dr. Weber, do you have anything to add on this slide?
No, there are many studies that have looked at SARS-CoV-2, but they look for the RNA, and that doesn't equate to live virus. So much of what you read about finding both surface contamination and contamination via the air is not based on finding virus that could actually necessarily affect people, but just remnants of the virus. So we need to keep that in mind.
So I think the point here is just to highlight that we focused a lot and talked a lot about filtration and ventilation, but there's really no filter or building system feature, despite all of the advances that have come out during the pandemic. None of them have been consistently proven to remove the virus that causes COVID-19 or really any other airborne infectious disease, other than dedicated, specially constructed hospital units that are known to have a special direction for air coming in, air going out, and changes in pressure that are built for this purpose. Everything is just additive, and the baseline infection prevention efforts would work, such as hand washing, wearing a mask, and spacing, and then just ensuring that you have frequent enough air changes, which occur in most buildings. Next slide.
Many of the school buildings are older with poor ventilation. Some of these classrooms don't have windows that support airflow. What does this mean for the risk of children and staff in these circumstances? And what can be done to decrease the risk in these circumstances?
So I think probably prior to going into the study, the original question was just asking about schools and classroom settings that may not be air conditioned or may not have adequate airflow. And I think for the most part, we've talked through just typical standard filtration systems that are built into standard ventilation systems, and ensuring that each school or each school district is aware of how their filtration system works and how their ventilation system works, so that it meets their necessity, their standard guidance for all of these things, and just some awareness of that. And then not belaboring the point, but also just repeating that the other things we talked about, masking and distancing, would work in those settings. I think the reason we included this study is at the time of the original webinar, there was a study that come out looking at the risk for severe illnesses among teachers and adults in school-age children. And there were questions about if this was directly related to schools. But all the study was saying was that they looked back at a 2018 survey. It was a population study, survey that looked at about 70 million US adults and defined them into possible or definite risk factors that are associated with COVID-19. And those risk factors include, so the line that's just showing 2.5 million were over 64 years. Risk factor meaning older age is associated with severe outcomes if you get COVID-19. And about 5 million had heart disease, 5 million had type 2 diabetes. This is just a description of the US population. And they subcategorized that survey into the number of people in the US population that are teachers, and then estimated that amongst teachers, we would expect that 32% of teachers have a high BMI or have a heart condition, which could increase their risk for COVID-19. But it does not answer the question about what is the risk associated with being in school or being a teacher if schools reopen, so to speak. And then when you look at specific data from schools reopening across the world, we have understanding that each country is slightly different from the United States in their COVID response, COVID management, and their school structure. This slide just shows experience in China. They looked through 68 kids over a specific period that had prior adult contact. So just rephrasing that, 68 kids were positive, and all of those, they had a prior, 96% of them had a prior adult contact. It wasn't really spread from interactions with other children. In France, there was a young child, a 9-year-old, that had COVID-19 and also had a few other respiratory viruses, influenza and picoRNA. Had many contacts at 3 different schools and I had no secondary exposure or secondary transmission of COVID-19, even though this child was able to transmit the flu. And finally, in Australia, 9 students and 9 staff that went across 15 schools that were all infected, and they traced almost 1,000 people, but there were only 2 secondary infections. I think the point of this slide was just to show that there are many concerns we have around kids going back to school, but SARS-CoV-2, so the virus that causes COVID-19, the transmission of that virus in schools may be far less important than what's happening in our communities. So what's happening in places people worship, people go to eat, people gather, than initially feared. And so the key points here are, yes, there are things we can talk about in terms of ventilation, improving our filters, and just improving the air movement in a room. But there are many other COVID prevention tips, cleaning, distancing, masking, that are more effective in preventing transmission. We can open windows and doors, but as you all know, there are unintended consequences associated with those. But it could be used in the right setting if the school setting allows for that. Surfaces are not the most likely way to spread COVID-19. However, they should certainly be kept clean, and there should be a cleaning schedule, and someone should have responsibility for cleaning. And community prevalence will reflect school prevalence. If we're seeing transmission in our local communities, we will see cases in schools. We shouldn't see spread if we have adequate protocols in place and people are masked. And of course, reduce COVID-19 by washing hands, wearing a mask, and staying 6 feet from others. Next slide, please.
Can UV light air purification devices in the air ducts help?
So UV light in high concentrations does kill bacteria and viruses, and in plants where they produce food, it's often used to clean the cutting boards and so on. However, there's no evidence that putting a UV light purification device in this above the ceiling in an air duct is going to do anything to prevent transmission in the room. It's not been studied adequately to demonstrate that. And of course, if I'm sitting 3 feet away from you and neither of us have a mask and I give a good sneeze, my droplets are going to quickly go those 3 feet and you can inhale them. Again, that's prevented by wearing masks. And it's hard to see why a UV device, even though it does kill viruses, sitting many feet away up in the ceiling is going to prevent that very short distance transmission. So the advice at the moment is not to purchase any of these devices until such time as they're proven actually to reduce COVID within enclosed spaces, which has not occurred. And again, the primary prevention we know absolutely works is wearing a mask.
So Dr. Weber, do you want to go through the slide?
I would be happy to. So the amount of UV light in public locations under current rules that would stop the virus in approximately 8 minutes is listed there. Many UV lamps are sold for homes, a low dose, and may take much longer to stop a virus. Now, UV light, as you know, which is why we put sunblock on when we go out in the sun to prevent skin cancers and others, does damage the skin. It also damages the eye, so you can't directly shine UV light on people as a disinfectant, nor would you put it up directly on the ceiling, showering people and environmental surfaces. So it has to be enclosed, and then you circulate the air either passively, just normally with airflow, or more commonly with a little fan in an enclosed space that circulates the air by the light. But only if the light has direct contact with the pollutants does it work. So yes, you can buy little UV lamps that are shielded and you can wave a few inches above the surface, but they're not as fast, as easy to use, just as a disinfectant wipe. And certainly it would work and does work for long distance diseases like tuberculosis to put them in air ducts. But again, there's just no evidence that it works to prevent airborne spread. And it's not an efficient, and has some concerns for using these lamps that could be passively moved over a surface, since if you inadvertently turned them up, or a child did, and shine that light into their face or on their body, it could damage your eyes and damage the skin. So we would not recommend the use of those UV devices.
Many schools are not air conditioned, and scientists have brought up concerns about heat exhaustion brought on by masks. What can be done to mitigate this risk?
So I'll tackle that one. It's true that masks have, people have a tendency when they have a mask to feel they're having more difficulty breathing. But in fact, the masks are medical masks and are specifically designed so that doesn't happen. And certainly homemade masks in general filter about the same, so that should not happen. Just the other day, I read about somebody, a marathon runner who ran a whole marathon, 26 miles, wearing a mask without difficulty. In general, unlike dogs which pant to cool themselves, we sweat to cool ourselves. So again, we don't pant, and having a mask covering your face doesn't really increase your body temperature, or in the absence of sort of severe respiratory diseases, severe asthma, for instance, does a mask impair your safe breathing there? Obviously, if you're feeling particularly hot, the best thing to do is obviously take off a sweater or a jacket. Obviously, if you have long sleeves on, just rolling up the sleeves can help. Simple fanning yourself, with a piece of paper could all cool yourself as well. Now, not really relevant now that we're in the fall, in the middle of the summer. Obviously, keeping open windows when the temperature outside where we live in North Carolina is over 100 degrees. If the room temperatures get up, really into the 100+ range, then it is possible, particularly if people are not drinking adequately, they could suffer adverse events, in which case, obviously, then you need to look at other ways for cooling them. And as you can see from here, wearing a mask is safe even while exercising. Here at the university, we've been having our athletes wear masks except during game time. So we're talking about football, soccer, field hockey, and other sports, and they're able to do that perfectly well. There's no evidence, scientific evidence, that wearing a mask can cause heat exhaustion, and for most people, wearing a mask doesn't harm, make them short of breath, or in any way handicap their breathing. Again, people with severe pulmonary lung diseases or sometimes heart problems, if they're having any problems, obviously take the mask off, but if you're having problems, you should speak to your local medical provider.
How long does the virus survive on surfaces? Cotton masks, metal doorknobs, glasses, desks, wood, and plastics. Can COVID be transferred through pens, surfaces, and other materials?
So the answer, the virus survives on surfaces for a few hours to a few days. It survives not very well on things such as paper, very short periods of time. It survives better at low temperature, low humidity, so will survive better in the winter than in the summer. And of course, the more virus that's on the surface, potentially as well. There are concerns that shared objects, pens and surfaces like keypads on a computer could transfer it, but what it requires, first of all, is that the infected person not be wearing a mask, and then they rub their nose and mouth, they touch the surface, they leave, a new person comes, and then touches that surface, does not perform hand hygiene, either with an alcohol waterless product or soap and water, and then touches their nose. So how can we prevent any possibility of transmission? It's quite simple. Obviously wear masks, and then you're not touching your mucous membrane, so you wouldn't transmit it. Good hand hygiene whenever before and after touching any shared object, and certainly before and after touching a mask. And I should say there are only a very few examples, despite the tens of millions of cases of COVID, that suggest transmission through a surface. So certainly it could be possible, but again, the predominant means of spread is short distance through the air. Wearing a mask also prevents transmission from contaminated surfaces, since you won't rub your mouth or your nose.
So I think this was in addition, this was a next slide that was in addition to the question that was just answered. Dr. Weber, we can go through this. I will just note before we do that, there was a comment about the lack of labeling of the x-axis from this paper, and that was the label was time. I don't know if you want to go through this.
Yeah, quickly, you can see that the survival on cardboard is the shortest. There survives a little longer in stainless steel and plastic. Again, this was the same study that put the virus in the rotating drum. That's why it looks like it survives so well in the air. That is a very artificial measurement for the reasons we talked about. Copper does have antibacterial and antiviral properties, and but of course, it's not practical to cover every desk, every chair, every computer console with copper in a school. And while it has been proposed for uses in hospitals and studied, the data does not show uniformly that it actually prevents infection. So this is more a theoretic use of copper than something that's recommended or practical at the present time.
And of course, the key points here are what we've said previously, which is if we are able to limit sharing of equipment, it's probably best to. So for example, pencils and pens, and then of course, wearing a mask and washing your hands or using a hand sanitizer. And this is alluding to all those things that were just mentioned. We already received packages, as you know, nearly daily for some people. People have already started to go to restaurants, hopefully in safe ways. And people are receiving takeout or delivery, and none of these have been main modes of transmission. I will say with restaurants, oftentimes the concern has been not so much the contact or the table you're touching, but the fact that unmasked people sit together for prolonged periods while eating or drinking. And so that could increase the risk, but not the surfaces.
How often are cleaning and disinfection needed to clear viruses on surfaces? What are the appropriate precautions for performing these tasks?
Well, in general, surfaces should be cleaned and disinfected once daily at the end of the school. Certainly whenever a surface is visibly contaminated, somebody vomits, sneezes on a surface, et cetera, it's reasonable to wipe the surface. And to the extent possible, again, wearing masks is protective, but to the extent possible for shared objects like a computer keyboard, it would be a good idea to wipe them down or spray them with a disinfectant. Anything that is labeled by the EPA or Environmental Protection Agency as a disinfectant on their list N works. And so there are many, many disinfectants. This is an envelope virus, and it's easily killed within 10 seconds by an appropriate disinfectant. So here I'll just point out, cleaning physically removes germs, dirt, and impurities by soap or detergent. And you do this when you wash your dishes in the sink, or if you often before you put them in a dishwasher. It's best to use when you're using disinfection, reusable or disposable gloves, and certainly soap will help get rid of the dirt and the grime, and that's appropriate. But it doesn't actually necessarily kill germs, including SARS-CoV-2. So then you need to use a disinfectant. So first you clean. Cleaning should always precede disinfection, and then you use a disinfectant that will kill the germs on the surfaces. Cleaning can have physical removal, but only if you wipe something and then throw the wipe away. If you take that wipe and move it from table 1 to table 2, it'll just spread the germs. But disinfection kills. You can use a disinfecting wipe. You can use a disinfecting spray. All of those work equally well and will rapidly kill germs on surfaces. And one should practice routine cleaning, ideally at the end of every day. All the touchable surfaces will be wiped. We're not worried about ceilings and walls and those areas. We're worried about chairs and tables and computer keyboards and doorknobs and things that people touch. Now, again, disinfecting are chemicals, so you do have to be careful about the use of chemicals. You don't want to spray them on someone's face or in their eyes, and you certainly want to, if the guidance on the manufacturer says to wear gloves, you should certainly do that. Most of these are designed to stay wet an adequate period of time, so you don't have to reapply them. But you do want to let the surface stay wet for whatever period of time is listed on the bottle. Usually somewhere between 1 and 10 minutes. You don't want to just spray it and then immediately wipe them off. It does take some time to kill the germs, but SARS-CoV-2 is quite easily killed. And again, some people may be sensitive to the spray and it can precipitate asthma in a few people, but that's uncommon. But nevertheless, you would like to make sure using them in appropriate ventilation. For young children, you obviously want to store them safely. You don't want them drinking the disinfectant, so they should be stored out of reach of young children or in a locked cabinet. Always read and follow the directions on the label to ensure safe and effective use. Now for bleach, just Clorox, the bleach solutions will be effective for disinfection for up to 24 hours. Generally, you could do a 1 to 10 to 1 to 100 dilution of bleach and water, put it in a tightly capped bottle, and generally leave it in the dark, not sitting by the light, which will make the chlorine less effective more quickly. Alcohol solutions with 70 to 90% alcohol can be used. Again, that should be isopropanol or ethanol. There have been a few examples recently of methanol being used. If people ingest methanol, small amounts can be fatal. So we should not be using methanol. All of those products have been recalled by the FDA, but isopropyl alcohol, so-called rubbing alcohol, or ethanol work very well. And they can be used depending upon how they're prepared for either surface disinfection or hand hygiene. I will remind you that alcohol is flammable, and you really don't want to leave alcohol bottles open to the air, and you certainly don't want to be splashing large amounts of alcohol on anything that would be electrical, such as a whole computer or a record player or something like that. That would not be safe to use alcohol near something that might be electrical. And again, safety first. So the key points: clean high-touch surfaces frequently, and those are really touchable surfaces. Limit shared equipment, have extra supplies, and clean and disinfect them between use and after use. Place cleaning in key and easily accessible locations for the staff, but inaccessible locations for particularly young students. Follow the manufacturer's recommendations on the bottle. We can't go through that since there are so many different products that are available, and use products that have been approved by the Environmental Protection Agency.
Have any studies determined the degree to which active coronaviruses on a surface can become airborne again after a surface is disturbed? And how might this contribute to the viral load over time?
So I am unaware of any studies there about that is, for instance, if someone sneezed on a chair and then sat on it, would that put the virus back in the air? There really is not any evidence that that can occur, but it's not been well well studied. And it does not seem like this would be a very common, if at all, even a possible mode of transmission. The idea that somebody sitting or banging on a table would take the virus that might have been deposited there, put it back in the air, and let you breathe it in. It's not been described for SARS-CoV-2 or for other respiratory viruses. So that does not seem that that would lead to transmission and something we have to worry about. Again, it's touching the surface and then touching your nose or your mouth.
There are many other resources available on the CDC's website. This was a video, but I don't think we need to play it. And most can use this, which will also be available in the FAQ document as well. Excellent.
I'm wondering if we might be able to switch over to a couple of Q&As from the chat. Would that be okay?
Yes.
All right. So what about this one? Would you advise, if applicable, to keep my office room door open? Also, would you advise for me to keep my office fan on? Dr. Akinboye, would you like to take that one?
Yeah, so I think partially because we're assuming here that people should be masked while they are in shared settings. And if people want to take mask breaks, the preference would be to do that with an office door closed. If it's open, ensure that your mask remains on. Presumably, if you don't need a fan, you shouldn't use it. If you do have a fan, you don't want to leave the door open where any of your droplets is pushing out into the hallway. So keeping the door closed might be a good idea. So it really depends on the context and if you're masked or unmasked. If you have to be with people in those settings, it's preferred to be masked if your door is open.
Thank you very much. Could you, Dr. Weber, maybe talk some about once COVID-19 is contracted, how soon can you recatch it?
So once you're exposed to COVID, the incubation period from the time you're exposed to the time you get sick varies from 2 days at the shortest time to about 14 days at the longest. Most people would become sick around day 5 to 7 would be the average. You can certainly be tested to see if you've been exposed. Most people would test about 7 to 9 days afterwards because by then there would have been evidence of infection. But again, a negative test within that 2-week incubation period, if you don't have symptoms, does not exclude that you have COVID. So you really can't test your way out of that 14-day period of being isolated, ideally staying home and not interacting with other people. Even a test at day 8 or 9, if negative, doesn't mean you still will not develop infection within that 14 days. Now, if you're symptomatic, then you can be tested to know if you have COVID or not.
Thank you very much. Dr. Akinboye, should staff wear face shields when spraying disinfectant to clean surfaces?
Depends on the disinfectant they're using. Most likely not. I think when you are using a disinfectant and spraying it on a surface, there could be a splashback. So some people opt to wear gloves, and some people you should be wearing your mask if you're in an indoor setting that's not your household. But except if there's a splash risk, they're actual face, not necessarily face shields, they are eye protection glasses that people wear when using chemical products, and those may be needed. But there shouldn't be anything special other than what you would use normally.
Great, thank you. So Dr. Weber, would you mind commenting on how severe is defined? There's more and more information about previously healthy individuals who are never sick enough to go to the hospital, but have been struggling with long-term symptoms, not just those who have pre-existing conditions. Can you comment more on this?
Sure, several questions. I think the simple way to break things down is mild to moderate disease, you can stay home. Severe disease, you need to come into the hospital. The Centers for Disease Control would say mild disease are people with just things like mild fever, cough, a little bit of shortness of, a little bit of throat pain without shortness of breath or evidence of pneumonia. Moderate illness are people who have a little more, have some cough there, have some X-ray evidence of pneumonia. Severe illness are people breathing very fast or low oxygen, and critical illness is people with respiratory failure or their organs are failure. Now, in general, the real question is, when do you need to go see a doctor? When can you stay safely at home? certainly if you have any symptoms that suggest COVID, fever, cough, sore throat, malaise, headache, muscle pains that are new, particularly loss of sense and smell and taste, you should call your healthcare provider and get tested. Now, whether you need to actually see somebody would depend on your conversations with that provider. If you're older or you have underlying diseases such as chronic lung disease, heart disease, liver disease, kidney disease, you're immunocompromised because you have cancer, you can't adequately take in fluids, or you're having a moderate to severe shortness of breath. For children, if they can't catch their breath, they're turning blue, they're crying quite a bit, they can't hold down liquids, then you need to go seek medical care. Ideally, if COVID is possible, you should call ahead and alert them that you're coming in. A whole separate issue now is for people who have COVID. We now know even people who just had mild illness never came into the hospital, and certainly people who have been in the hospital going for 2 weeks to as long as 3 months, 30% or more of them will still have symptoms that last. Fever is not one of those persistent symptoms, so if you've had COVID and you develop a fever, you need to immediately call your healthcare provider because it's likely you have a new infection. But certainly many people will continue having sore throat, shortness of breath, cough. They may have nauseousness. They may have mental confusion. So again, if you have lingering symptoms, you should go see your healthcare provider, calling them ahead of time, of course, and making an appointment. And this is becoming so common that here at UNC at the Medical Center, we are beginning a post-care COVID multi-specialty clinic led by our experts in rehabilitation, but will include experts from heart disease, lung, infectious diseases, psychiatry, as well as geriatrics to deal with these long-term problems.
Thanks very much, Dr. Weber. Dr. Akinboye, how much are we exposed to COVID-19 when we're walking about on a regular day outdoors? And what about potentially in the school environment? What's the exposure there?
So just walking about outdoors, the exposure risk is likely low. It's important to still wear a mask if you're going to be in crowded settings, because people that are coming closer than 6 feet could potentially exchange droplets even if they're not directly interacting. So in a crowded spaces, wearing a mask will reduce your risk of exposure. Walking about outdoors without any true close exposure to anyone, it's not floating around in the air, so there's really no risk in that setting. I think indoors, again, we've pushed for encouraging masking in that setting because the risk of transmission is higher indoors, knowing that ventilation and air movement is less than what occurs outdoors. The way to measure that may occur in standard studies or in very specific settings. It's hard to put a number in that in this context, but I think a lot of studies have actually shown that there's a low risk of transmission when kids are in congregate settings, so schools or daycare, and they are masked, and anyone that has symptoms does not come to school, does not attend school, and no staffer is there with symptoms. Very low risk of transmission in those settings.
Thank you. Dr. Weber, another one from the chat. I've read about UVC lighting fixtures adapted for installation in an HVAC system. It promises to sterilize the air as it passes through the UVC illuminated chamber. Is there any research that supports this type of assertion?
So again, as we talked about earlier, there's no question that UV devices with circulating air over them do kill germs and bacteria. And there is evidence for diseases that are transmitted very long distances, meaning somebody in one room, hospital room or home or workplace could transmit it to people rooms away, that they do work to prevent something like transmission of tuberculosis. Again, COVID is spread over relatively short distances directly, and there is no evidence that putting in a UV light disinfection unit in the ceiling within the air ducts would prevent transmission of COVID within that room. And there's no evidence in any case of transmission from room to room of COVID.
Thank you very much. I'm not certain that I see many more questions here. Maybe Dr. Akinboye, could you maybe comment on the type of mask that's the best for COVID and whether or not disposable masks are okay to reuse?
Yes, so we had a webinar dedicated to masks, and I think that webinar should be available both on our website and on the FAQ document. The preference or the sturdiest mask will be those that have a double layer or at least have room for a filter to be inserted. A cotton mask or polyblend mask is probably fine. In some settings, a surgical ear loop mask may be needed, and those may be interacting with children that are unable to wear a mask, maybe due to their developmental stage, such as in special needs classrooms, or interacting with students who have some symptoms, for example, in a nursing, in a nursing room, or nurses that have to evaluate students that come to school with some symptoms. Other than those, I think we've mentioned that neck gaiters, bandanas may not have the same protective ability as some of the other types of masks, but any face covering is better than no face covering. So emphasizing the use of face covering or mask would probably be where we should spend our efforts.
Thank you. And a question for Dr. Weber. What % is considered a low community prevalence? Is that 1%? Is that 2%? Something else?
So that's a little hard to define because it depends on the test. Some tests are better at finding people who are infected or not. Depends on whether you're testing infected people or asymptomatic people. We find much lower rates if they're asymptomatic, and it depends on who's getting tested. But that said and done, generally a prevalence of in the community of less than 1%, particularly if those are asymptomatics, would be considered low. Testing numbers over 10% would be considered high, and in between would be considered moderate.
Great, thank you so much. I think that wraps up our session for today. We are really pleased to have spent some time with you and hope to see you next week.